Welcome to this clinical explainer on uterine fibroids or leiomyomas. Look, if you're a doctor, a nurse, a clinical officer, or an advanced practice provider, you already know that uterine fibroids are literally the most common pelvic neoplasm in females. But today we're going way beyond the basics. We're going to translate that complex pathophysiology, the nuanced imaging, and the very latest management guidelines into practical, highly relevant strategies you can use in your everyday practice. Think of this as a rapid-fire clinical documentary tailored just for you.
Okay, let's dive right in by anchoring our learning to a real-world scenario. Picture this. You've got a 35-year-old nulliparous patient sitting in your exam room. She's telling you about severe menorrhagia, really heavy menstrual bleeding, and this constant dull pelvic pressure that is absolutely tanking her quality of life. So, what's your very next step? How do you counsel her? To answer that, we're going to use this exact case to guide us from the cellular origins of her symptoms all the way to a shared decision-making treatment plan.
Here is our roadmap for the explainer today: case presentation and pathophysiology, epidemiology and risk factors, FIGO classification and symptoms, evidence-based diagnostics, key differential diagnoses, and finally, patient-centered management. Section 1. Case presentation and pathophysiology. Let's start by zooming in on what's actually happening at the cellular level inside our 35-year-old patient's uterus. The absolutely crucial point here is that a leiomyoma is a benign, hormone-sensitive smooth muscle tumor. But what actually makes it tick? Well, these are monoclonal neoplasms. That means the whole thing arises from a single, transformed myometrial cell. Under the influence of estrogen and, actually importantly, progesterone, these abnormal cells go through clonal expansion. They upregulate their hormone receptors and drive this crazy, dysregulated production of extracellular matrix. We're talking collagen, fibronectin, proteoglycans. This dense fibrotic process is exactly why we colloquially call them fibroids. Now, check out this classic whorled pattern of smooth muscle cells. It's like a microscopic fingerprint for a fibroid. These cells have really well-demarcated borders, which totally distinguishes them from the normal surrounding myometrium. And genetically, this isn't just random bad luck. The vast majority of these tumors are driven by key somatic mutations, with the MED12 gene mutation being by far the biggest culprit. Basically, we're looking at a localized genetic misfire that creates a dense, highly vascularized, and hormonally hyperresponsive tumor. Section 2. Epidemiology and risk factors. Zooming back out from the microscope to the population level, let's contextualize our patient and figure out why she, specifically, might have developed these.
So our patient is 35 and nulliparous, which right off the bat are classic predisposing factors. Fibroids are heavily influenced by the life cycle of reproductive hormones, which is why we largely see them in females aged 25 to 45. Early menarche, meaning reaching it before age 10, which gives more lifetime exposure to circulating estrogens, is a massive risk factor. But we also have to talk about the stark health disparities here. African American females have a 2 to 3 times higher incidence of fibroids compared to white females. They often get them at a younger age, the tumors are larger and more numerous, and they suffer way more severe symptoms. The literature shows this isn't just about race. It's a really complex interplay of environmental exposures, chronic stress, and potentially biological factors like widespread vitamin D deficiency, which actually alters those fibrotic pathways.
Section 3. FIGO classification and symptoms. To really understand our patient's specific complaints of both that heavy bleeding and the pelvic pressure, we've got to map out the anatomy. This is a brilliant illustration of the FIGO classification system. As clinicians, we all know size matters, right? But location is actually the primary driver of symptoms. The FIGO system categorizes these fibroids based entirely on their relationship to the endometrial cavity and the serosal surface. You've got your submucosal fibroids pushing right into the cavity, your intramural fibroids buried within the muscular wall, and your subserosal fibroids growing outward into the pelvis.
And you know, this location completely dictates how the patient presents. Submucosal fibroids, even the tiny ones, are notorious for causing severe, heavy menstrual bleeding and are heavily linked to infertility and pregnancy complications. They physically alter uterine contractility and totally disrupt the endometrial vasculature. On the flip side, subserosal and large intramural fibroids are the usual suspects for your bulk symptoms. That means pelvic pressure, urinary frequency from pressing on the bladder, or even constipation from compressing the bowel. Now, since our patient has both heavy bleeding and pressure, she likely has a myomatous uterus with multiple tumors, maybe a submucosal one driving that bleeding, paired up with a bulky intramural or subserosal one causing her pressure.
Section 4. Evidence-based diagnostics. Our clinical suspicion is incredibly high at this point, based on our history and our physical exam, where, let's be honest, we probably felt an enlarged, irregular, mobile uterus. So let's talk about the evidence-based diagnostic workup we need to confirm it. Look, before jumping straight to advanced imaging, remember your highly accessible foundations. A basic CBC is absolutely mandatory here to check for iron deficiency anemia from all that menorrhagia. Next up, the transvaginal and transabdominal pelvic ultrasound. This is your gold standard frontline diagnostic tool. And the best part is, whether you're in a state-of-the-art academic medical center or a resource-limited rural clinic, this is your go-to starting point. What you're looking for here are the classic leiomyoma signatures: well-circumscribed, hypoechoic, solid masses. You might also spot some acoustic shadowing, or if the fibroid has actually outgrown its own blood supply and started degenerating, you'll see some calcifications. Transvaginal ultrasound is exceptionally sensitive, literally up to 100%, for detecting fibroids in a uterus that's smaller than 10 gestational weeks in size. Now, if your patient's ultrasound shows a distorted cavity, or if you're gearing up for complex interventions, you've got to level up your imaging. Saline infusion sonohysterography is fantastic for precisely mapping exactly how far a submucosal fibroid is protruding into the cavity. But actually, if you're planning a complex myomectomy or considering uterine artery embolization, a pelvic MRI with contrast becomes absolutely invaluable. It maps the exact depth, location, and vascularity of every single fibroid, which perfectly guides your surgical approach. Section 5. Key differential diagnoses. Hold on a second. We cannot just blindly assume it's fibroids. An enlarged uterus with bleeding and pain has a wide differential, and we actively have to rule out other serious conditions. This framework is crucial for distinguishing our patient's benign fibroids from other potential pathologies. Is it adenomyosis? Well, in adenomyosis, the endometrial tissue infiltrates the myometrium, creating this uniformly globular, boggy, and tender uterus, rather than the firm, irregular masses of fibroids. Is it endometriosis? That usually presents with severe, chronic pelvic pain and dysmenorrhea without necessarily enlarging the uterus itself. And of course, we have to mention the rare but terrifying leiomyosarcoma. While imaging can't definitively rule it out, a rapidly enlarging, highly vascular, solitary heterogeneous mass, especially in a postmenopausal patient, should trigger major alarm bells for malignancy. Section 6. Patient-centered management. We've reached the climax of our patient's journey, formulating that treatment plan. And honestly, this is where the art of medicine truly meets the science. Remember, treatment is never one-size-fits-all. We follow a tiered approach that has to be heavily guided by shared decision-making. You've got to sit down and ask the patient, what are her primary symptoms? Does she want to preserve her uterus? And absolutely most importantly for our 35-year-old, does she desire future fertility? For totally asymptomatic patients, expectant management is perfectly fine, but our patient is suffering right now, so we have to intervene. When we look at medical management, specifically to control that heavy menstrual bleeding, we have a pretty solid arsenal. Tranexamic acid or oral contraceptives are great first-line agents to just get the bleeding down. The levonorgestrel IUD is also highly effective, though a quick clinical pearl, you've got to be cautious if a submucosal fibroid is heavily distorting the cavity because the expulsion rate goes way up. What about GnRH agonists or antagonists? Well, these put the patient in a temporary hypoestrogenic state, shrinking the fibroids and stopping the bleeding dead in its tracks. But because of bone density loss and menopausal symptoms like hot flashes, these are really just used as a short-term bridge to surgery or to buy time to build up her blood counts. If medications fail or those bulk symptoms just won't quit, we start looking at procedures. Comparing these interventions is so vital for our 35-year-old. Uterine artery embolization, or UAE, is a brilliant, minimally invasive radiologic procedure that literally chokes off the blood supply to the fibroids, shrinking them down. It preserves the uterus, sure, but its long-term effects on future fertility and pregnancy complications remain kind of uncertain. So, because our patient is 35 and nulliparous, if she tells us she desires a future pregnancy, a myomectomy, where we surgically remove just the fibroids while painstakingly reconstructing the uterus, is the preferred evidence-based gold standard. Just be sure to counsel her that there's roughly a 25% chance of recurrence down the line. We have to set realistic expectations. Finally, for patients who have completed childbearing or maybe those who have failed all other therapies and just want guaranteed definitive relief, surgical intervention via hysterectomy remains a reality. Looking at this intraoperative view, it really highlights just how massive and anatomically distorting these benign tumors can become. It thoroughly justifies why definitive surgical management is sometimes the absolute most compassionate and effective route we can take.
As we wrap up this explainer, I really want to challenge you to reflect on your own clinical practice. The very next time a patient walks into your clinic with abnormal bleeding and bulk symptoms, how will today's evidence reshape your conversation with her? Are you going to lean more heavily on the exact location of the fibroid to explain her symptoms? Will you tailor your pharmacotherapy bridge a little more effectively? Remember, treating fibroids isn't just about managing a physical mass. It's about restoring a patient's quality of life through precise, incredibly personalized care. So keep learning, keep questioning, and I will see you in the next explainer.